I was asked to talk at this meeting on combination therapies in myelodysplastic syndromes. One of the areas in which this has been developed the best is in higher risk myelodysplastic syndromes. And one of the reasons for that is higher risk myelodysplastic syndromes has an increased likelihood of evolving to acute myeloid leukemia. Because we have a drug that's shown a survival advantage in higher risk MDS in azacitidine, that's become the backbone for adding other agents to see if we can improve on that overall survival. We conducted the largest prospective study in higher risk MDS in North America, in which we randomized patients to receive azacitidine monotherapy, azacitidine combined with lenalidomide, or azacitidine combined with a histone deacetylase inhibitor, Vorinostat. The reason we chose those combinations is there was outstanding phase 2 data showing response rates for those combinations of over 70% in these patients, which more than doubled what had classically been seen with azacitidine monotherapy at 35%. In these studies, while we didn't find a huge amount of excess toxicities in the combination therapies, we ran into a big problem. And that problem was that among the 280 patients who were enrolled across the United States and Canada, a lot of patients had their doses lowered arbitrarily by their treating doctors, or they had them stopped entirely when the protocol didn't dictate that. So we saw that patients received azacitidine for a longer period of time than they did the combinations. As a result, we probably didn't see the efficacy we could have for those combinations. We did see a non-significantly higher response rate for lenalidomide and azacitidine over azacitidine alone, with a response rate of 49% versus 38%. We also saw an interesting signal for the combination of azacitidine and vorinostat, where once patients had stopped therapy, they actually had a longer survival for the combination of azacitidine and vorinostat versus azacitidine alone. What that indicated to us was that there's probably some deeper response for the combination therapies if patients can stay on those therapies long enough. And that's one of the greatest challenges we have with combination therapies with azacitidine. We're seeing a lot of drugs that are being added to azacitidine. There have been some studies looking at checkpoint inhibitors, for example, monoclonal antibodies, like an anti-CD47 monoclonal antibody that was just highlighted at ASH, and other agents that are new to the market.